Narcolepsy is a chronic brain disorder that is characterized by a classic tetrad of excessive daytime sleepiness, with sleep attacks that can strike at any time.
Other symptoms include cataplexy, which is a sudden bilateral loss of muscle tone, paralysis and hallucinations. There is no cure for narcolepsy, but some of the symptoms may be controlled with medications such as modafinil, an oral amphetamine-like drug which promotes wakefulness by stimulating the motivational and cognitive brain circuitry. Despite its FDA approval over a decade ago, the precise mechanism of action is still unknown. However, there is a plethora of evidence indicating its effectiveness in treating narcolepsy. So in terms of the role of modafinil in the management of narcolepsy, only some people will experience totally normal wake times. About 50% of people will see an improvement in the ability to stay awake and a reduction in the total number of involuntary sleep episodes. It doesn't appear to affect natural hormones such as cortisol, melatonin and growth hormone. Therefore, studies suggest that it doesn't actually interfere with voluntary naps. Side effects do include headache, dry mouth, insomnia, nausea, anxiety, tachycardia and dermatological reactions. However, these do have relatively low incidence, making modafinil appear to be the first non-toxic drug that can improve the disturbing symptoms of narcolepsy. We do have to be mindful, however, there are possible contraindications in pregnancy due to spontaneous abortion and fetal growth retardation, and therefore it is used as a last resort in children. Now, let's take a look at the current theories on the mechanisms of action.
It is well known that modafinil works as a weak dopamine reuptake inhibitor in the striatum and nucleus accumbens, which increases locomotor activity through the increase of extracellular dopamine concentrations. However, it is believed to work on multiple other systems. Firstly, in the hypothalamus, modafinil has been found to activate orexins and hypocretins in areas that increase wakefulness, along with increasing dopamine and norepinephrine levels in the tuberomammillary neurons, which causes an increase in histamine levels. Secondly, it's been found to activate glutaminergic circuits and inhibit GABAergic neurotransmission in the thalamus, and at higher doses in the hippocampus and striatum. It was found to enhance the effectiveness of gap junctions in the thalamocortical loop through the prevention of gap junction exocytosis between GABAergic interneurons and possibly even glutaminergic pyramidal cells. It also has a pro-electrotonic effect in the reticular activating system and is thought to increase arousal through cholinergic inputs to the thalamus.
Currently, research is being done on modafinil versus placebo, cocaine and amphetamine abusers. Results have shown that modafinil decreases the activation of the ventral tegmental area and the anterior-cingulate cortex. It also increases the levels of dopamine, glutamate, orexins, histamine and noradrenaline, and it decreases levels of GABA in the brain via direct and hypothesized indirect pathways. Some of the effects are reduced euphoria caused by the illicit drug, increased time to feel the high and thus reducing the attraction of the drug being enjoyable. It also decreases the negative withdrawal effects of discontinued drug use, such as depressed mood, anger, irritability, anxiety and sedation. It also improves memory, learning, reasoning and cognition. It also decreases the impulsivity and self-administration and sensation-seeking traits typically seen in addicts. The drawbacks of modafinil are that it doesn't work in smokers for nicotine addiction, and only a limited group of studies have shown these results, which differed based on variables such as gender, dosage, and the length of treatment. Modafinil has a long half-life, low toxicity, and it doesn't intensify the adverse effects caused by the illicit drugs. This makes it suitable in the rehabilitation of substance abuse. So what is the abuse liability of modafinil? Let's first define what abuse liability is. It is the likelihood that the use of a drug with reinforcing properties in a non-medical context can produce toxicity within an individual, and this self-administration can cause harm to both the abuser and the society they live in. In contrast, dependence liability is the likelihood that a drug has reinforcing properties and toxicity associated with its administration, but the use of the drug is not necessarily a threat to the user or public health. Drugs of abuse are commonly inhaled or injected because this leads to a quicker high. The same cannot be done with modafinil due to its physicochemical properties such as instability at high temperatures and low water solubility. Subjects with a history of fluid substance abuse have described modafinil as less provoking of feelings of euphoria and pleasure, giving it a very low, if any, abuse potential. Modafinil activates more discrete areas of the brain involved in arousal and wakefulness, whereas amphetamine-like drugs of abuse have a more widespread effect.